Everyone, welcome to our November 2022 AIDS Clinical Conference. I'm going to give it another minute or so as people are logging on, and then I'll introduce our esteemed speaker. Go ahead and get started. Good morning, everyone. Welcome to our November 2022 AIDS Clinical Conference. It's my pleasure to introduce our speaker today, who really is well known among the ECHO community, Dr. Brian Wood, who is an associate professor of medicine at the University of Washington in the Division of Allergy and Infectious Diseases, and is very nationally known for his leadership role in the Mountain West AETC project ECHO for HIV, among very many other things that he does. So we're pleased to have him do our annual update on state of the ART, and here he is today. Thank you so much.
Thanks, Trisha. There we go. It's really an honor to be back. Great to connect with you all, and excited to talk about long-acting ART. So let's dive in. I have no conflicts of interest or financial relationships to disclose. My only disclosure is I am doing this talk from Lusaka, Zambia, where the internet usually works, but there are occasional random power outages. So if I disappear, I will be right back, but hopefully all will be stable. It has been quite a year for long-acting ART. It has been a saga. I will talk about long-acting injectable cabotegravir rilpivirine, ask you a couple of questions about it as well. Would love your participation in the polls and in the chat. There is some ongoing controversy around it. There was a big FDA meeting about it, about using it for people with detectable viral loads last week, and I think there's a fair amount worth talking about. We will also talk about lenacapavir, a capsid inhibitor likely coming soon. It's had its own challenges, but is likely coming soon, and then the latest changes and plans for islatravir, which studies of which have resumed. So with that, I'd just like to ask you this question, Chris, if you wouldn't mind putting up the poll. Thanks. Whether you're a prescriber or not, how many of your patients or clients are currently receiving long-acting injectable cabotegravir rilpivirine for HIV treatment? My memory from doing this last year is most people answered 0 last year. I would just like to see if that's changed. My general gestalt from ECHO case discussions and other conversations is that implementation has picked up a bit, but of course is not without its challenges. Thanks everyone for weighing in. I see answers rolling in. I appreciate it. Again, whether you're a prescriber or not. And Chris, I think let's go ahead and display that. Is everyone seeing the answers? Maybe if someone could just unmute or chat real quick. Is anyone seeing the answers?
Yes, I can see the answers.
Perfect. Thank you, Trisha. Okay, so about half, 1 to 10, that is my impression. I think a lot of clinics, a lot of practitioners do have a couple folks receiving this these days, and then quite a few with 0, and 5%, 11 to 23%, one person, 21 or more. That's quite impressive. So please share your experience as we go. And if I could ask you one additional question, again, this is just based on your experience for your patients or clients who have expressed interest in long-acting injectable cab rilpivirine, but then didn't end up started. What do you feel has been the most frequent reason? Insurance coverage issues, drug resistance mutations, detectable viral loads, difficulty adhering to visits, or you talk about it and then they choose daily oral ART. Or if there's another reason, please feel free to put that in the chat. I'd be very curious to hear if there's another reason as well. Again, for everyone, for patients, clients, anyone you've talked to about long-acting injectable therapy, what has been the reason folks haven't started it if they haven't? Again, I appreciate the responses. Matt, thank you. Drug is too expensive regardless of whether insurance pays. Yep, absolutely. Chris, let's go ahead and display that for everyone. All right, insurance coverage issues, absolutely. Drug resistance, not as much. Detectable viral load for some. Difficulty adhering to regular clinic visits. Choice, absolutely. I appreciate that, and we will come back to some of these thoughts as we go. So the first part of this talk, a large chunk of this talk, I am going to talk about long-acting cabotegravir. Some of it will be review, but there are a lot of ongoing conversations about it, controversy about it, challenges with it. I appreciate the comments in the chat as well. Absolutely, those are challenges and barriers. As a reminder, the indication, the FDA indication for long-acting cabotegravir is for adults and adolescents to replace an antiretroviral regimen in persons with HIV RNA or viral load below 50 copies. Individuals should be taking a stable oral antiretroviral regimen with no history of treatment failure and no known or suspected resistance to either of the drugs in the combination. Remember, these are long-acting drugs. They stay in the system for months to even years. Neither of them have the high barrier of resistance as dolutegravir, bictegravir, or darunavir. So these are important things to keep in mind. Here's a brief timeline. The initial approval, January 2021, with every 1 month dosing. Approval expanded to every 2 months in February 2022, and then the label update to make oral lead-in optional. I'm not going to review the data for those updates today, but we do have slides on all of that data on the National HIV curriculum. Remember that the options are monthly or every 2 month dosing. Remember that the oral lead-in is now officially optional, and there is data showing the efficacy and safety. Remember that regardless of every 1 month or every 2 month dosing, there is an initiation phase, either a higher dose with every 1 month dosing or with every 2 month dosing. The first doses should be a month apart. Here are the recommended dosages. Also remember the recommended site. The recommended site is actually ventrolateral gluteal or glute medius. This is a diagram we developed for the up-to-date article on this, just as a reminder, because it's easy to forget. The alternative is dorsolateral glute maximus, and I'll talk later about a potential alternative site that may be approved in the future. Remember also there's a recommendation to use a longer needle if BMI is above 30, although that longer needle I don't believe comes in the dosing kit. Also, BMI is a pretty crummy marker for just about anything, but that is what's in the package insert, and this is the recommendation for every 2 month dosing. Again, remember, oral lead-in optional. There is an initiation phase. There is a continuation phase. It's every 2 months, but the dose remains higher than with every 1 month dosing. Again, please see our National HIV curriculum for much more extensive slides on the data and the recommendations. But before I turn to some of the controversies around this combination, let's revisit this, the associated factors that have been described as predictors of virologic failure, or those factors associated with virologic failure per the large phase 3 randomized controlled trials. So in the 3 big trials, the number of virologic failure cases was 13, so pretty darn low. These are, as far as I can tell from digging into these studies, virologic failures despite on-time dosing, though in some of the studies that is less clear. And in a multivariate logistic regression analysis, these were the factors that came out as associated with virologic failure. Proviral rilpivirine resistance mutations, you can see the odds ratio there, by far the strongest predictor. Subtype A1 or A6 virus, which has been associated with lower threshold for integrase resistance, sort of it's more fragile with integrase. You can see there the odds ratio, BMI above 30, again, just barely for BMI above 30, statistically significant, and lower rilpivirine trough concentration. I revisit this because I think a lot of stock has been put into this, and because I'll be coming back to it and talking about it more. Now you can see a list of the factors at the bottom that were not statistically associated with virologic failure based on this data. This was updated at ID week. The presentation at ID week had a total of 23 cases of virologic failure, still pretty low, and largely agreed. But these first 3 factors, let's talk about these first 3. These first 3 can be known before starting long-acting IM cabotegravir. Subtype, you usually can see on the genotype, BMI, and then rilpivirine resistance mutations, either based on genotype or proviral genotype. We could debate whether everyone should get a proviral genotype or not before starting this, but let's look at this. Let's look at the importance of these factors. So here I've bolded those individuals who developed virologic failure who had none of those 3 clinical factors, those who had 1, those who had 2, and those who had all 3. So here's your total of 13 cases there. But what you can see here is that really, statistically, what is associated with virologic failure on this combination is having 2 or more of those baseline clinical factors. That's really what stands out as being statistically associated, even though proviral rilpivirine resistance mutations were so strongly associated. No one with only that risk factor alone developed virologic failure in these large trials. Now, these were very carefully selected patients. This is a very small number of clinical endpoints. Maybe somebody who's better at stats than me can comment on the validity of a logistic regression like this with so many clinical endpoints, but a lot of stock has been placed into this. It really is 2 or more of these clinical risk factors that seems to portend virologic failure, assuming on-time dosing. So we'll come back to this, but with that, I'm going to ask you another poll question that gets at some of the controversy and something that has been talked about a lot lately. So I'm going to ask you to weigh in. Again, this is a slightly different topic, but let me ask you this. I'm curious your answer. What is your comfort level prescribing or recommending long-acting injectable cabotegravir for an individual who doesn't meet the FDA eligibility criteria? So let's say someone who has a detectable viral load who does struggle with missed doses of oral ART or who has missed clinic visits. We went through the FDA indication, which is really replace stable oral ART in somebody with stable virologic suppression. So what's your comfort prescribing or recommending this outside of that scenario? I see answers rolling in. I really appreciate it. Please keep them coming. Thanks also for the comments in the chat box. Matt, Jonathan, very much agree with your comments about barriers. And Chris, thanks. Let's go ahead and display that. Okay, 3 folks very comfortable, 8 comfortable, 22 uncomfortable, 8 very uncomfortable. It's a really interesting spread. Again, I really appreciate it. We'll talk a little bit more about this data, and then would love to hear from you. Perhaps comment in the chat box why you chose what you chose. But with that, let's go into some of the recent data. These are hot topics. We've discussed this on Echo. We've discussed it on Journal Club. Again, there was an FDA meeting last week to review some of the data, but I'd really like to dig into this a bit and then hear your comments and whether this changes your opinion or your comfort level at all. So first, let's talk about a study that has been published this is from the UCSF Ward 86 group. This is a demo project of long-acting cabotegravir for individuals with or without detectable viral loads. So Ward 86 is the safety net clinic for San Francisco City and County. They serve over 2,400 adults with HIV, the vast majority of whom have government insurance, Medicare, Medicaid, or local ADAP support. You can see here the proportion who identify as Black or as Hispanic. And overall in this clinic, an estimated 15% have viremia, 10% chronic viremia. And among that group with chronic viremia, they've described higher rates of mental illness, stimulant use, and unstable housing. Now, they also have a clinic called Pop-Up, which was established in 2019, which really gives extensive outreach and support and resources to individuals with unstable housing. My general gestalt is there's a lot of similarities to our MAX clinic, to the MAX providers. If that is incorrect, please feel free to jump in the chat box and educate me, but that's my general impression. It is a extra resource clinic for individuals, especially those who have unstable housing and need additional support. They have published that since launching that clinic in 2019, viral load suppression in that group has improved. Now, the protocol for long-acting cabotegravir, I think, is super interesting. So they included individuals with or without undetectable viral load. Individuals had to be willing to attend injection visits, to receive 2 gluteal injections each visit, and resume oral ART if injections were interrupted. They also had to give 2 contact methods. So one could be phone or text or MyChart, and the other had to be friend or family member or case manager. So they had to have backup contact. They excluded any evidence of rilpivirine resistance, although interestingly, they did allow up to 1 integrase mutation, which I think is interesting and goes back to the study we were previously talking about. Hep B was allowed only if they were willing to continue or start Hep B therapy, and they did favor a direct to inject approach, meaning avoiding the oral lead-in, regardless of viral load. If an individual was viremic before starting the long-acting therapy, they received an individualized plan for adherence support. This was a sort of tight collaboration between the clinic and the public health team, case managers, home and street-based nursing services, community injection sites, and there were financial incentives for visits and labs. It was $10 grocery store vouchers. Everyone had a monthly RNA or viral load check, and a resistance test at the second injection visit if they remained viremic. The team also did a regular multidisciplinary review of patients every 2 weeks in general, or every 1 week for the pop-up patients. And then every 4-week dosing was required. It's commented there was a transition to every 8-week dosing allowed if there was viral suppression at 6 months. But as far as I can tell from what they reported, no one actually made that transition. So this really is only every 4-week dosing included. Now, the pharmacy team was really tightly involved. They did a review. The first visit was with the pharmacy team so that they could review eligibility per their protocol, review Hep B status, review for any drug-drug interactions. There aren't a ton of drug-drug interactions with long-acting cabotegravir, but there are a handful. And then the first visit for each patient was with the pharmacist to discuss eligibility and the process. They had a bilingual pharmacy staff member who could call within 1 week of the first injection, who could call and text for appointment reminders, as well as missed visits. Patients also kept a month of oral ART on hand in case of missed injections by at least 7 days. Remember, the target date, or the window for the target for giving an injection, is plus minus 7 days. So for monthly dosing, it's 28 days plus or minus 7. If an individual missed by more than 10 days, a viral load and genotype resistance test were checked. And for unplanned missed injections, there were attempts to contact, there was in-person outreach, and then there was a repeat loading dose if a person missed by more than 42 days, which is a little different than what's in the package insert. The package insert for monthly dosing says reload if more than 60 days have gone by, so they were a little more conservative there. Now here are the participant characteristics. You can see the median age. You can see the majority were cisgender men. The 4 who were not cisgender men, if I remember right, there were 3 cisgender women and 1 transgender woman. You can see 21% identified as Black, 26% as Hispanic, Latinx, 33% reported unstable housing, and 3 individuals, or 8%, homeless. There were fairly high rates of stimulant use. And then this, I think, is super interesting, and I'll focus on this and we'll come back to this in the next slide. So those who had a suppressed viral load proximal to their first injection, so that was 24, that was the majority, and then those who were viremic proximal to their first injection, that was 15 individuals. For those who were viremic, you can see their mean viral load and standard deviation and the CD4 counts for those 2 groups. So next we'll focus on those 2 groups. So the 24 with suppressed viral load before starting, or at baseline, meaning before starting cabotegravir, and the 15 who were viremic. So here on the left in the green bar is those 24 who were viremic proximal to their first injection. And here is their outcome. 24 maintained viral suppression. So 100%. It's really in line with the clinical trials. You can see here that most got direct to inject, meaning avoiding the oral lead-in. And you can see here the median number of injections, which was only 6, range of 2 to 8. So not very long follow-up here. And then you can see here on the right, the bluer bar, the number who had detectable viral loads before starting cabotegravir, 15, and you can see on follow-up, 12 achieve a suppressed viral load. The asterisk here is what's commented in the manuscript is that those other 3 who didn't achieve suppressed viral loads were headed that way. They actually had achieved a 2-log decline by a median of 22 days. And if you see the manuscript, there's a nice graph of all the viral load trajectories. All of the individuals who were viremic at baseline had a direct to inject strategy, no oral lead-in, and the median number of injections again was 6. Now there's a lot of interesting comments in what they published as well, including 2 patients achieved a suppressed viral load for the first time in 10 years. They had not had a suppressed viral load in over 10 years. Both were in this group that were viremic at baseline. There was even 1 individual who had a baseline significant integrase mutation, N155, which is sort of intermediate resistance to cabotegravir. That person, they commented, was suppressed, had been suppressed for 8 months. So is this really promising and positive, or is this too short of follow-up for us to make any conclusions? If you were the FDA, if you were the guidelines committee, what would you do with this? So I'll let you ponder that. Overall adherence was high, 87% had only on-time injections. Missed injections didn't lead to viremia for anyone. There were only a small number of late injections. Sorry, I misspoke. 87% had on-time injections. There were a small number of late injections. Late injections did not lead to viremia for anyone. 2 individuals in this study who were experiencing homelessness received injections at community sites, a harm reduction mobile van, and a community clinic, again in partnership with public health and street-based nursing services. They commented that 1 individual who was homeless received nearly all their injections and blood draws through the mobile van, and the drug was very well tolerated, which is the general experience, I think, in the trials and in clinical practice. So their conclusion is that this shows preliminary short-term effectiveness of every 4-week dosing with or without viral suppression in a diverse urban clinic serving publicly insured patients with frequent housing instability and stimulant use. Again, I'd like to ask your conclusions. I'll tell you what I think of as the limitations. It's an overall small N. Follow-up was less than a year. And this is a very unique setting. They have centralization of insurance authorization. They have extensive outreach, drop-in visits, injections in the field. And then I forgot to comment on this, but of the 51 individuals who entered the protocol, they included 39 who had received at least 2 injections. That was at their data censoring for this cohort study. That is who was included, but that means 12 individuals only had 1 injection and weren't included, and we don't know how those 12 folks are doing. So I would really like to see longer follow-up from this. So will results change with longer follow-up? Will findings be reproduced in larger studies in other settings? Will payers cover the meds? They also comment that in California, they have a unique setting for coverage for long-acting CAB, rilpivirine. The government insurance programs added them to the formulary very early. ADAP was covering co-pays. So this is a unique setting and may not be generalizable to other geographic areas. So again, if you are the FDA reviewing this, if you are the guidelines committee reviewing this, what do you do with this? What do you recommend? Let's talk about one other study briefly, and then I'll ask you another question. I would like to hear your comments, and I'll turn to the questions in the chat box. Let's look at this compassionate use study just a little bit and compare and contrast. So compassionate use, it basically is before a drug is approved, a clinician can petition for early usage of the medication, and there has to be a compelling reason. So a provider petitions to the drug company and says there's a really compelling reason, and then in return, that provider has to provide quarterly data, quarterly updates. So it's not an RCT, it doesn't have the rigorous data collection of an RCT, but I think there are some interesting findings here. So I'll talk about it, albeit a little bit more briefly. So in this compassionate use or early access program for long-acting CAB rilpivirine, they included adults with HIV who needed parenteral ART due to either psychological or physical condition, or they had a history of prolonged oral ART non-adherence with progressive HIV disease. You can see here the list of reasons for which individuals were granted early access to long-acting CAB rilpivirine. They did exclude anyone with resistance to cabotegravir or rilpivirine, except for the K103N. They did have to have an established relationship with a provider and a history of adhering to their clinic visits. That really was sort of a marker of their ability to adhere to the injection visits. And they couldn't be eligible for a phase 3 randomized trial. So these really were individuals who either had advanced HIV, low CD4, high viral load, or had an opportunistic infection, or had a really significant reason why they couldn't enter a trial and be randomized to oral ART. So these are individuals being treated with long-acting CAB rilpivirine who would not fall into the FDA indication and who would not qualify for a randomized trial of that 2-drug therapy. Here are the participant characteristics. I'll compare and contrast the last study a little bit. So a much higher proportion who were female at birth. The authors commented that they did have a fair number of individuals who acquired HIV perinatally. You can see here the median age, 66% had a current AIDS diagnosis. And then here again, 7 individuals in this study had a suppressed HIV RNA before starting long-acting CAB rilpivirine as compared to 28 who had detectable viral loads. You can see those who had detectable viral loads often had very high viral loads with a median of 60,000 and an individual with a viral load up to above 10 million. You can see here the median CD4 count was relatively low. And then as opposed to the UCSF study, the majority here did get an oral lead-in. Again, these individuals were being treated prior to approval, prior to that label update saying that the oral lead-in is optional. Again, all received every 4-week dosing. The median follow-up here was 10 months, range of 1 to 47. And here again on the results. So on the left, these are the 7 individuals who started long-acting cabotegravir with a viral load below 50 copies at baseline or before starting. You can see of those 7, 6 maintained viral suppression. 1 individual did develop virologic failure and did develop a new cabotegravir resistance mutation. And then on the right, in the bluish bar, of 28 individuals who started this 2-drug long-acting therapy with detectable viral load, 16 achieved a suppressed viral load. Now, I want to comment that of those individuals who didn't achieve a suppressed viral load, 6 developed virologic failure, and 6 simply didn't have long enough follow-up to be included. 6 had only received 1 injection or had such short follow-up that they weren't included. So of the 28 individuals, 16 achieved a suppressed viral load, 6 did not. Of those 6, 6 developed new rilpivirine resistance mutations, 2 developed new cabotegravir resistance mutations. The other thing I want to note here is that of these 7 individuals who did not achieve virologic suppression, achieve or maintain virologic suppression, it's interesting to look at what happened to them afterwards. They all 100% ended up on a boosted darunavir-based therapy. Now, after switching to the boosted darunavir oral ART, 2 of 7 achieved a suppressed viral load. I think not surprising given we know this is a group who had significant challenges to taking oral ART every day. But I think this is a key point that if an individual develops a virologic failure on this combo, what they are likely to need is boosted darunavir-based ART. So their conclusion is that this is a valuable treatment option for individuals with advanced HIV and limited other options, and who have issues preventing enteral administration of ART. Again, limitation small n, no comparator group. This wasn't an RCT. Follow-up again was less than a year. They did not provide any adherence data, and a lot of individuals here were asked to take an oral lead-in. So again, individuals with significant oral ART challenges who were asked to take an oral lead-in, I wonder if that limited their findings a bit. But here's what I'd like to do. I'd like to review what the panel says in a little bit, and then I'm going to ask you again about your thoughts. So let me highlight this. What does the Department of Health and Human Services say in their guidelines? So they updated this in September. This is the adult and adolescent antiretroviral HIV treatment guidelines, just updated 2 months ago. They recommend against the use of long-acting ART in people who have detectable viral load due to suboptimal adherence or who have ongoing challenges with retention and care, except in a clinical trial. So this is the clinical trial. It's an ACTG study, 5359, or Latitude. This is a study which is enrolling individuals who have a history of missing doses of oral ART, who have a detectable viral load, offering them incentives and an individualized oral ART regimen, and then monitoring viral loads. And if they achieve a viral load by 3 months, I think it's if they achieve a viral load below 200 by 3 months, they'll correct me if I'm wrong, then they are randomized to either oral ART or the long-acting option. So there is still a randomization. They may not all end up on long-acting ART. So what the FDA meeting last week was about was meeting with ACTG leadership, clinical guidelines leadership, and other leaders to say, hey, if a randomized clinical trial like this isn't feasible, could a single-arm study or could a different design be possible to really answer the question of, is this an effective option that should be considered and that should change guidelines and should change the drug label for cabotegravir. Now, we don't know the outcome yet, but I think we'll be hearing more about it in the near future. And in the meantime, I think as clinicians, we really have to consider if an individual has advanced HIV, has limited options for whatever reason, and they're going to die without therapy, then perhaps this could be the right move to go ahead and start this if it's covered, if you get access to it, if you have all those resources to support adherence. I think there are a few other things that need to be considered. We've talked a lot about these. Again, if a person misses doses, I think they're likely to develop resistance. They're likely to need boosted darunavir, fostemsavir, other salvage agents. And I think they should be counseled about that and should be counseled that this currently is off-label and based on limited data. But with that, let me ask you this question again. I know it's weird. I'm going to ask you the question again. After seeing all that data, does it change your comfort level? Just go ahead and weigh in again, please, Chris, if you don't mind throwing that up. And then while folks are answering, I'll look at the chat box. So what's your comfort level prescribing or recommending this for someone who doesn't meet FDA eligibility criteria? You answered this once, answer it again. Now you've seen two studies that have been published. The unpublished data, we did see a presentation at ID Week from the OPERA cohort. They had a handful of folks who started with detectable viral loads and overall did pretty well. But again, follow-up less than a year. So are you comfortable with this, or do we need more data and more follow-up? Yeah, thanks everyone for weighing in. Super interesting. Let me look at the chat box. Yeah, thanks Noemi for the comment. AJ, does it matter which oral medication? Forgive me that I lost track of when you put that in there. So if you could clarify, that question for me, that'd be great. Christian, thanks for joining. Would love to see longer follow-up. Yeah, thanks Christian, appreciate the comment. Elaine, very promising. Small number, short follow-up, totally agree. Labor intensive for max type patients, absolutely. Yeah, Elaine, couldn't agree with you more. Appreciate that. Liz, do you mean every 2-week dosing or is every 4-week dosing possible? Liz, again, I think I lost track of when you asked the question. So if you clarify for me, that'd be great. Colin, these settings also had a lot of resources for monitoring and outreach. Absolutely, Colin, so true. Not every site is going to have all of those robust resources for outreach, for doing injections in the field, for monitoring. I mean, this really is staff admin time intensive. So absolutely. Thanks everyone. Chris, let's go ahead and broadcast those. So hopefully everyone can see the results. I think largely similar, though whoever was very uncomfortable actually became more comfortable. That's interesting. So I think largely a similar spread, but looks like perhaps comfort level improved a little bit is my gestalt there, but feel free to put in the chat box whether the data made you feel more or less comfortable and why. AJ, backup oral meds, you know, they didn't comment on that. I think you mean for the UCSF study for missed doses, which backup oral meds did they have on hand at home? They didn't comment on that. There is a recommendation in the package insert that individuals can take oral rilpivirine to replace doses if they have a planned miss injection, but I don't know for sure if that's what they used in that study. Liz, you were saying it for San Francisco study and compassionate use. So forgive me, Liz, if I'm not understanding 100%, but yeah, if I misspoke, it really should be every 4-week dosing. It's really every 4-week dosing that was used in these trials. Every 4, every 8-week is your option when considering long-acting rilpivirine. Both those studies used every 4-week. Thanks, Hillary. We can't see the questions. Okay. Okay. If you open up the chat box, I wonder if you could see the questions. If not, I will do my best to reiterate them. Thank you, Hillary. So super interesting. I really appreciate everyone weighing in on this. Again, it's a topic of a lot of conversation right now. I think we will see more data. I think we will see updates in the future, and we'll see if we see an update to the guidelines or to the FDA package insert. Latitude study is multi-site. I believe we are a site. Whether we still have enrollment spots or not, I don't know. If anyone from the ACTU team could weigh in on that, that would be that'd be awesome. RBI or colleagues, if you are on there, do we still have sites for Latitude? Gotcha. Thanks, Hillary. I will do my best to reiterate the questions. So I'll just mention this briefly because, again, there's one more potential update about rilpivirine in the future. We did see this small study of injections in the lateral thigh that was presented at the AIDS conference. 15 individuals without HIV got an oral lead-in, then got monthly injections in the vastus lateralis, and overall did well. The pharmacokinetics were comparable to gluteal injections. Side effects were mild, very similar to giving it in the in the glute. So this could become a potential alternate site for administration. Some individuals might have a contraindication to injections in the glute due to fillers and other factors, or this may be an alternate site if someone is developing side effects at the gluteal sites. Could this be done as self-administration? I think that's an active topic of controversy and conversation. Not that a person couldn't do it, but do we need that touch point? Do we need that check-in every month or two of the person coming to the clinic to know how they are doing with this? I think, again, that's an area of controversy, and I do not know if it is approved for utilization in the site, if the FDA will make a comment about self-administration or not. Would be curious your comments as well, if you would recommend this for self-administration to a patient or client. Still enrolling. Thanks, Chris. Really appreciate it. We have slots. Ooh, actually, Liz and Chris, I think those two answers may not jive. So thanks for answering. If we clarify that, that would be awesome. Yep, thanks, Colin. Absolutely. So this is where I think that could be utilized. So with that, let's turn to a different long-acting injectable, which also has some very interesting data. Let's look at lenacapavir, a capsid inhibitor. So what does lenacapavir do? So it blocks multiple steps of the HIV life cycle. You can see here the capsid, this sort of conical core that houses all of the viral genetic material. And so what lenacapavir does is it gets in there and it binds, and it really makes this this housing structure too stiff and misshapen. And then it also blocks some of the proteins necessary for entry here. So really it blocks this this whole structure from getting in through this nuclear pore complex. But then also, because this capsid becomes so stiff and misshapen, it interferes with disassembly, and then later in the life cycle also assembly and viral maturation. And one thing I'm going to recommend is that you look at, you watch David Spock's amazing talk on this on our Echo YouTube channel. David, I mean, David describes this and has such, amazing teaching and slides on this, like no one else does. It is an incredibly high yield 20-minute talk. So if you want to know more about the mechanism, please see that one. The dosing, because it is active at such small concentrations, the dosing has potential for oral daily or weekly or subcutaneous every 6 months. This is a summary of the phase 2 and 3 treatment and PrEP studies. I know I'm focusing on treatment today, but I am going to mention one thing about PrEP because I think it's really important. I want everyone to be aware. So these are the 2 treatment trials, which we will talk about in more detail, Capella and Calibrate. And then the 2 PrEP trials. So Purpose 1 is currently ongoing in South Africa. So they are offering every 6 month subcutaneous lenacapavir. I shouldn't say offering, they're randomizing participants to every 6 month sub-Q lenacapavir versus daily oral TAF FTC. And they are enrolling cisgender women aged 16 to 25. So not only is this important for lenacapavir data for PrEP, but also for daily oral TAF FTC for PrEP for cisgender women. So this is going to give us very important data in 2 big ways. And then Purpose 2 is a multinational study enrolling cisgender men, transgender women, trans men, and gender non-binary individuals, all of whom report sex with men, and randomizing enrollees to sub-Q len every 6 months or daily oral TDF FTC. Now, you may have seen that the studies of lenacapavir were put on hold just about a year ago, December 2021. It wasn't because of side effects of the drug. It was concern about compatibility of the drug with the vial it was being stored in. And then just as of May 2022, the hold was lifted because the company that makes it addressed this and changed the vial type. And then as of July 2022, the new drug application has been resubmitted, and the FDA is going to review it by the end of December of this year based on the Capella data. So really what they are going to review is lenacapavir every 6 months as part of combination therapy for heavily treatment experienced individuals with HIV. So we'll talk more about that data. The other thing that happened in August is sub-Q Len was approved by the EU, so it was approved in Europe for this same indication for heavily treatment experienced individuals with HIV. So we can get a few insights from looking at the European package insert. But first, let's talk about Capella. This is the study that may lead to approval for individuals with extensive treatment experience and extensive drug resistance. So this is a phase 3 randomized controlled trial of lenacapavir plus optimized background regimen. So what that means is basically the most active combination of other drugs possible. And they enrolled highly experienced individuals. They actually offered this study to anyone aged 12 and above. So they actually offered it to individuals of adolescent age, though as far as I can tell, no adolescents enrolled. They had to have virologic failure on their current ART with a viral load above 400 and resistance to at least 2 agents from at least 3 of the main ARV classes, and less than or equal to 2 predicted active agents. And then what they got, so there was a randomized cohort and a non-randomized cohort. In the randomized cohort, what individuals received was either oral lenacapavir plus their regimen with which they currently had virologic failure, or placebo for 14 days. Then there was a comparison of the lenacapavir oral drug to placebo and how much viral load suppressed. I'm not going to show you that. Not surprisingly, viral load suppressed significantly more with the oral lenacapavir option. But then these individuals got sub-Q lenacapavir every 6 months with their optimized background regimen for 52 weeks. And the other group got another 14 days of oral lenacapavir and then also switched to the sub-Q option. There was also a non-randomized cohort you can see at the bottom who got the 14-day oral lenacapavir with optimized background regimen, then the sub-Q option. So what I'm going to show you is the data for the randomized cohort at 52 weeks and for the non-randomized cohort at 26 weeks. These are the participant characteristics. I will say this study has been praised for being more inclusive than a lot of other studies. Jeannie Marazzo, who a lot of you know, wrote a really nice commentary in the New England Journal and commented on this. You can see here the median age range. Again, no adolescents actually enrolled, but they did have some in a younger age group. You can see the percent female sex at birth, percent who identified as Black or Hispanic Latinx. And then you can see here the median viral load, those with viral load above 75,000, and the median CD4. Again, these were individuals with a long treatment history and generally advanced HIV. And then at the bottom, you can see the number of fully active agents in the optimized background regimen. So 17% had 0 active agents to take with lenacapavir, 39% only had 1, and 44% had 2 or more. Here is the 52-week efficacy data for the randomized cohort. You see overall, 83% achieved a viral load below 50 copies. That was 30 out of 36 individuals. And then you can see here the efficacy broken down by how many active agents were in the optimized background regimen. But I need to highlight that these numbers are really small: 4 out of 6, 11 out of 14, 15 out of 16. So the 95% confidence intervals were actually quite large and overlapped. And this wasn't actually a statistically significant difference between these groups, but you can see some suggestion here that the number of active agents you can combine with lenacapavir may be critical to its success. And that's not surprising. We saw in the ibalizumab and the fostemsavir studies that individuals really needed to have at least 1 active agent to put with that drug for it to be efficacious. Here is a summary of efficacy results for the randomized cohort at 52 weeks in the left column and the non-randomized cohort at 26 weeks. Again, I should have mentioned this, there were 36 total in each arm. You can see the percent who achieved viral load below 50, percent below 200. And you can see here the number who met criteria for resistance testing, so who either didn't suppress or had virologic rebound. And importantly, of those individuals who met criteria for resistance testing, 4 in each arm had evidence of capsid mutations or lenacapavir resistance. So resistance to this drug can occur. Of those 8 individuals, so 4 in each arm, of those 8 individuals, 4 of them had 0 active drugs in their optimized background regimen, and 4 clearly had inadequate adherence to their optimized background therapy. So basically they were at very high risk of developing lenacapavir resistance. You can see there the bottom line, the most frequent capsid mutations, which have been described. So resistance to this drug can happen. It seems potent, effective. It's every 6 months, which is great, but it must be combined with other active therapy. And with missed doses of that other active therapy, resistance can occur. Now, I was just curious, so I looked at the European package insert. What do they recommend for lenacapavir? And I'll share this because I think it's interesting. So they say indicated for treatment of adults with multi-drug resistant HIV for whom it is not otherwise possible to construct a suppressive regimen. They do say, even though this is a sub-Q drug, they do say each administration should be administered by a healthcare professional. So they do not recommend self-administration. Again, I think that's because with injectable therapy, it's so long acting and the risk of missed doses or the risk of not getting it right is so high, but we could debate whether individuals would be, whether we should support self-administration or not. Now, there's no dose adjustment needed for renal or hepatic impairment. There are very few drug-drug interactions. The package insert does have a lot of comment about emphasizing the importance of adherence. And you can see here, there is an oral lead-in. There's basically a 14-day oral lead-in with dosing on day 1 and 2, then day 8, then day 15 is when the first sub-Q injection begins, and it's repeated every 6 months. Now, the oral version is film-coated tablets that shouldn't be crushed, but can be taken with or without food. So whether the FDA will follow suit and make the same recommendations, I don't know, but I do think we'll hear something from the FDA within the next 2 months. Let's talk about the other study that may lead to approval of lenacapavir in the future for other individuals, such as individuals who have never received antiretroviral therapy before. So this is a phase 2 study. So we're not yet at the point of FDA reviewing for treatment-naive individuals, but this is a randomized open label trial of lenacapavir plus other therapy for treatment-naive individuals. You can see the enrollment criteria here. And interestingly, enrollees were randomized 2 to 2 to 2 to 1 to these 4 groups. So the first group got sub-Q lenacapavir every 6 months with daily oral TAF FTC. The second group got sub-Q lenacapavir every 6 months, also with daily oral TAF FTC. The asterisk here is because they did get that 14-day oral lead-in before that, but that was their initial therapy. And then if they were suppressed near week 28, just before week 28, then they transitioned to these 2 interesting arms, lenacapavir sub-Q every 6 months with TAF alone every day, so 2-drug therapy, sub-Q len every 6 months, and then a TAF pill once a day, or sub-Q len every 6 months, plus a bictegravir once a day pill. That's not commercially available. I don't know why that was chosen, but that's what was done here. And then this group in the blue continued oral lenacapavir. They received and continued oral lenacapavir plus TAF FTC all daily. And then the final group got big TAF FTC oral daily. So what I'm going to show you is the efficacy results at week 54, which we saw at CROI last spring. So here is each group. Above in the bar graph, you can see the proportion who achieved a suppressed viral load, very high in all of the groups. In the table, in the corresponding table below, in the corresponding columns, you can see the number of participants. You can see those with confirmed virologic failure, and then those who developed new resistance. And I'll just mention, Nina, I'm seeing your comment, so I will respond. Calibrate did not permit patient self-administration as far as I'm aware. I'm nearly certain that's correct. If anyone knows otherwise, please jump in and correct me. So two of the individuals who developed virologic failure developed capsid resistance. This person, this first person in the sub-Q len plus bictegravir arm actually developed it quite early before even transitioning to sub-Q len plus bictegravir. So if we go back here, they were in this gray box randomized to eventually do sub-Q len and PO bic, but they actually developed their virologic failure and resistance earlier while taking len and TAF FTC. And what they developed this M184V first, and then developed the capsid mutations. Again, they both occurred pretty early. We know that because they went back and tested stored samples. The 184V occurred 2 weeks in, which makes me wonder if it actually had been transmitted and was there and not realized. And then the capsid mutations occurred at week 4. So again, this is a very promising drug in a lot of ways, but resistance to it can develop. The other person here in the PO len plus FTC TAF arm developed only capsid mutations, no resistance to FTC or TAF, which makes me posit that they probably were getting their injection, but at some point just totally stopped their FTC TAF pill because there was no drug pressure and no resistance developed. So that's phase 2. Phase 3 is, phase 3 will happen, and we may see an approval in the future for lenacapavir for treatment naive individuals. But again, it's one active long-acting drug, long-acting injection. It does have to be combined with other therapy. One thing I've wondered for viremic individuals who absolutely, who have huge challenges to oral ART, if this is approved, could one sub-Q dose of lenacapavir and then monthly or every 2-month IM cabotegravir be combined? There's no data for that, but I do think it's something that in the future will need to be considered, and hopefully we'll see some data around it. But with that, let's turn to this drug, which is also super fascinating, and then I'll do my best to address any additional questions or comments. So islatravir is an NRTTI. I'll talk about what that means in a moment. It also has had its share of difficulties, though some of the studies, not all, have resumed. So islatravir as an NRTTI is a nucleoside reverse transcriptase translocation inhibitor. So it's a little bit different than an NRTI. I mentioned this last year, but I'll mention it again because I think we will be hearing more about this drug and NRTTIs in the future. So whereas NRTIs basically are incorporated into the chain, and because they're missing the 3' hydroxyl group, are just act as immediate chain terminators, no more nucleosides can be added. These drugs have a different chemical structure. See the references at the bottom if you want to get really into the chemical structure and mechanism. But basically they do two things. So they basically bind super tightly to the reverse transcriptase enzyme and don't allow the enzyme to translocate. They don't allow the enzyme to vacate and open up a position in order to add new building blocks. And so that leads to immediate chain terminations, somewhat similar to the NRTIs. But then they also sort of cause a change in chemical structure such that if translocation does occur and if additional nucleosides are added, there's a delayed chain termination effect such that it becomes no longer viable. Again, if you want to get into the detail in this, the chemical structure has been described, the mechanism has been described in more details, but the reason people are excited about it is because it does seem that because of this mechanism, it's active in the setting of existing NRTI resistance. It seems to have potent viral load reduction at very low doses, plus a high barrier resistance. It seems like it works in the setting of a 184V. It seems like, for reasons I don't understand, it may even be sensitized by a K65R. And then, because of the long half-life, there is potential for daily, weekly, or monthly oral dosing, or even, you may have seen headlines a while ago about a yearly implant for PrEP. It also appears to be metabolically neutral, and the drug company who makes it is combining it with doravirine and promoting that, look, these are both relatively metabolically neutral drugs. So there's reason to be excited. However, you may have seen that there was an FDA hold put on this drug, like there was with lenacapavir, but this one is different. This one is because individuals in all of the trials, treatment trials and PrEP trials, developed a decrease in total lymphocyte count and CD4 T cell count, actually B cell count as well. And it seems that islatravir triphosphate, the active drug, so it's phosphorylated like NRTIs, gets into lymphocytes and other cells, and high levels actually seem to cause apoptosis. So December 2021, about the same time as the lenacapavir hold, these drug trials were put on hold. But then just 2 months ago in September, the hold was lifted for treatment trials with lower dose. So why was that done? So here's one study that led to that lift of the hold. This was a phase 2 study that compared doravirine islatravir, so a combined 2-drug pill, to doravirine TDF. This was for treatment naive individuals. Everyone also got 3TC for the first 24 weeks, but then they were just on that 2-drug therapy, doravirine islatravir, doravirine TDF, ongoing. And then what the investigators have done is they've gone back and they've looked at all the changes in laboratory parameters, and it's really notable here. So here's TDF, let's call that the control, and here's the change up to 72 weeks in total lymphocyte count, CD4 T cell count, and B cell count. Now, in this phase 2 trial, it was a dose-finding study. So you can see here the doses that individuals were randomized to, either islatravir 0.25, 0.75, or 2.25. Now, 0.75 was initially the target dose. That is initially what was thought to be the best dosage and what was going to go forward. And actually, at 72 weeks, everyone switched to this dosage. However, look at these change in total lymph, CD4, and B cell counts with 0.25. Looks pretty good, versus 0.75 versus 2.25. So it seems like the higher the dose is, the worse this effect is. And then what they saw was for individuals on the lower dose, on 0.25, who at 72 weeks switched to 0.75, things got worse after the switch, and vice versa. Individuals who started on 2.25 and at 72 weeks switched to 0.75, things got better after the switch. So this effect does seem to be dose dependent. It does seem to be reversible, and it did not seem to be associated with any increase in infections, which is reassuring. They also looked at efficacy, and there was no difference in virologic efficacy between the different dosages. Also at a recent meeting, we saw a modeling study that predicted that 0.25 milligrams may still be active against 184V, but I don't think we know that for sure. So what is going to happen, what the FDA has said, is that the treatment trials, whether they are for treatment naive individuals or whether they are switch studies for suppressed individuals, can resume as long as they switch to this lower dose of 0.25. However, the PrEP studies have been completely discontinued. At least that is my understanding. If anyone knows differently, please correct me. But the weekly dosing, the monthly dosing, and the yearly implant have such high dosages that they are not thought to be safe for this reason. So treatment trials will resume with the lower dosage. As far as I can tell, all of the PrEP trials have been discontinued. That said, the company that makes islatravir does also have an islatravir prodrug in the works. They have another NRTTI in the works. So I don't think we have seen the last of this family of new, potentially long-acting medications. So with that, I'll wrap up. And I am happy to take questions. I will take a look at the chat box as well. Thanks for everybody for weighing in. Thanks for posting the link to David's video. And feel free to fire away. Oh yeah, Trisha, thanks.
Thanks, and thanks so much, Brian, for that amazing talk. It's definitely a new era of options for patients, and I know that there are some logistical barriers and other considerations, but thank you for summarizing all that data. And
absolutely,
there was a couple of questions. There's one question in the Q&A that people may not be able to see. I've heard about some people who were suppressed becoming viremic on Cabrel, and can you say anything about that?
Yeah, thanks so much for that question. And I also have heard that in our Project Echo case discussions, we've heard about a couple of cases of folks who seem to be great candidates, started, and then either developed virologic failure or developed blips that then suppress. So this is the opposite story of the UCSF data. So these are individuals who are thought to be good candidates, started, and then surprisingly became viremic. So I've heard the same. It's a small number. It's anecdotal so far, but your point is so well taken. I really think we need more data, real world, if you will, demonstration projects and other analyses looking at this in clinics like Madison Clinic and others, so that we really understand the true predictors of virologic failure. I will finally say that, you know, in the clinical trials, there were a small number of individuals who did develop virologic failure despite on-time dosing. It was less than 1% of folks in the every 4-week dosing study and 2% in the every 8-week dosing study. So there are a small number of individuals who develop virologic failure despite on-time dosing. Whether that's the phenomenon you are hearing about or not, I don't think we know, but I think we need to understand this better. And I really appreciate the question.
Thank you. I think you got to many of the questions in the chat. There is one from Matt Mieterschmidt. I don't think that you answered that one. Would love to hear thoughts about potential effect of rilpivirine resistance on near-term, future long-term injectables.
Yeah, hi Matt, thanks for joining. Great question. So the near-term future injectables like lenacapavir should not be affected by rilpivirine or other NRTTI resistance. And actually, I didn't mention this, but in the lenacapavir studies, the individuals who didn't suppress and developed lenacapavir resistance actually went on to take oral integrase inhibitors and NRTIs, basically dolutegravir, bictegravir, and NRTIs, and did fine. So there's not a lot of overlap between current long-acting injectables and resistance, and then lenacapavir resistance. There's also not overlap between lenacapavir resistance and other salvage drugs like ibalizumab or fostemsavir or maraviroc. So I think for that, we can be reassured.
Thank you all so much. Thank you again, Brian. I know we're at time and people could ask you questions all day about ART, but thank you so much and enjoy the rest of your day, everyone.